Okay, so good afternoon, everybody. Welcome to the webinar. I'm Alex O'Neill. I'm Code's Head of Compliance, and thank you all for joining me on your lunch breaks. As always, it's appreciated. Hopefully, this will be of real value to the profession, to members and non-members alike. And we're going to be discussing COVID-19 auditing and what we believe here at Code inspectors will want to see, and explaining what that's about, what you should be doing, in our opinion, what we've done for you in iComply, how to create your own audit if you want to, if you're not an iComply member and you're going down that route as well. But before we get into that, we'll just talk about the aim. Obviously, the aim, as always, is to help practices create the evidence that inspectors will want to see, and also obviously to help you to stay on top of your SOPs, etc., and to make sure that everything is all right and running. Just a little bit on pass rates, which I think is really interesting to look at. We've been, and this is a little bit of information on what's going on with the CQC. We've been tracking iComply pass rates against everybody else since they changed the inspection in 2015. And obviously this year, if we look at this year, 2020, what we can actually see is that, you know, we've got an 87% pass rate as opposed to a 16% pass rate in the profession. Now that is a little bit, those stats are a little bit skewed by COVID, in the CQC are focusing on bad practices, or not bad practices, but practices that could do with some help at the moment. Let's phrase it that way. And that does mean that, but what that also means is that hardly any iComply practices have been touched at all in the last 6 months, because we're generally considered by the CQC to be low risk practices. And you see, obviously, the average over 2015 to 2020, we have maintained this 10-point lead pretty much since we started this and we started tracking it. Now, there are some providers out there, or people who might say they have more, but we've obviously we've got almost 2,000 practices using the iComply system. We're very, very happy with the figures and the results, and we're getting higher than everybody else in the profession. So just talking about what's on the horizon and a little bit of an update and what we're hearing from the CQC. Obviously at Code, we've been massively excited with the acquisition of, apologies, not sure what just happened there. I don't know if that's me just leaning on my keyboard. We've been massively excited with the acquisition of Isopharm and what that means for us here and for iComply and future products, etc., and how we get everything working together. So that's been really, really interesting, and we're looking towards what we can do with that. We are working on iComply group reporting. So for any groups who are signing up to iComply, they're going to have some really solid group reporting tools to look across the whole group. And we're considering bringing that to a practice level as well. Digital audits, you'll all be very glad to know. This is something that we wanted to do since we went to version 3, but something like, you know, the IPS audit tool, that sort of intelligence that you get in the audit tool, and it's not just a ticking boxes, it will tell you whether or not the answer you've said is the right answer, and it will prompt you to do a related to do off the back of that. We are really proud of the work we're doing on digital audits, on digital logs as well. We're going to start that work soon. We're going to merge how much do people love Isopharm logs? Wouldn't it be brilliant if they're inside iComply? That's another project that we're going to be doing for our members. So we're just going to keep building on the value inside iComply and just making it a better and better product. We have an aggressive roadmap for developing the software after we had the investment by August Equity, and we're looking to do more and more and more. So it's really exciting times here for us. We're getting to do the things that we really wanted to do, and obviously talking to you about what those are. And as always, we're open to feedback. So if there's anything you'd love in the system, and you think it's really needed, then I will get that. But I'm looking forward to, we're working on the infection control audit at the moment, looking forward to getting that into the system for everyone. We're also working towards a September document release. Things in there, for example, off the top of my head, we've got a hygienist and therapist audit that everyone's been asking for a long time. There's a few other things we wanted to get in, but that people have been asking for, but COVID's obviously been a real focus for everyone in the profession. But we will be looking at that list again, and really, you know, based on the feedback people have been giving us, there are certain documents. I don't want to spoil it right now. I'll talk about it on future webinars, but that's really interesting. The CQC inspection changes. This is just something we're keeping our eye on, because the CQC are in consultation right now, and I might have some exciting news coming out in a bit on how we as a group, the Code membership, can pick up this conversation with the CQC. So watch this space for that. But the CQC inspections, it looks like the day of the routine inspection may be finished. What are the CQC looking to do? They are asking questions about, what do people think about ratings again? It seems like the ratings question is on the table again. What would that mean? Would we have more focused inspections more recently, or more and more frequently, but smaller inspections? Would we have? So it's all, the inspection is all up for discussion by the CQC. Now, it could be that they stick how it is. So as a profession, if we're really happy with what they're doing right now, if we think it's fair, if we think it's balanced, then we can have that conversation with them. If we think it's unfair, or they should do something more, or we do want ratings, we don't want ratings, we think it's unfair that all other professions get rated and we don't, then we can have that. If we don't want ratings, then it's really, really interesting time to engage with this with the CQC. So we're working on that for you, and we're going to be working on that with you at some point as well. So that's really exciting. Registration delays, just for anyone who's thinking of registering a practice, their normal 10 to 12 weeks has gone up to about 15 weeks at the moment. There are delays, and they are asking for more information than they used to. But obviously, if you are a member or thinking of becoming a member, once you are a member, then we can advise you on that. We can tell you what documents you need to submit, because they are asking for more than they used to be asking for now. What else? Just a little bit of information I've just had from the CQC, or from conversations with the CQC, is that a lot of people have been putting washing machines in their practices to deal with clinical clothing. Now, we're going to look into this for you. It's literally fresh this week, but there are water regs around what type of washing machine you have. And if you've put a domestic washing machine in your practice and you're putting clinical clothing in, that probably isn't going to cut it. You need the certain water regs that require certain washing machines, and I think they're about a minimum of £2,000. So for those of you who've put washing machines in your practice, you might want to start looking into that. We are starting to look into that, and we'll have some information soon. But I know the CQC are going to be writing a Mythbuster on this, and they were happy for me to share this information to give people a head start on looking at it. And obviously, they're not going to come down on anyone like a ton of bricks. They are interested in letting people know and then giving people a chance to fix it. So it's obviously something new that's come out of COVID. So that's just something to put on everybody's radar. Moving swiftly on from that. Okay, so what's today's webinar about? We're going to talk about COVID-19 auditing. Now I'll go into sort of the reasons why in a bit, but essentially, we've had to do a lot of stuff very quickly. As a profession, we've not worked at this pace before. Maybe when HTM came out, we had to do something similar to this, but we were given a year. We had HTM landed on our desk, and we had a year to implement it. This has been really fast. There's been a lot of information, a lot of things you need to do, a lot of things you need to keep on file, a lot of things your team need to be doing differently. It's been a massive change to how we run our practices, from the whole patient journey, all the way from patient contact to them leaving your practice. And that's a lot of information, and we're only human. And we may have trained everybody on this when we had our SOPs in place, but are we really sure that everyone's following every letter of every SOP? Have we maybe missed a bit of the guidance and not put it in, or we've forgotten to put something on file? I'd say, yeah, I'd say probably in most practices there's, a few errors, of understandable errors have been made. And this is why, well, I'll get onto that into the next step. This is why the guidance, the FGDP guidance, says we need to audit. So this is where this is coming from, this angle. But what I'm going to cover in this webinar is, what's your responsibility? I kind of just covered that a little bit. Where is this coming from? Some required reading, from my recommendation for required reading in order to be able to do this. I think it's really important to always talk about basics when you talk about auditing, but what is effective auditing? What does an effective audit look like? And what are you doing with that? There's less of this these days, but some people get confused between logging and auditing, where logging is, say, data collection, and auditing would be analyzing that data and looking at what you want to do with it and what you need to fix. So we'll just talk a little bit about that. Now, as always, with a code audience and people on iComply, this. I've been banging this drum for 5 years or something. So, but I think it's always good to mention it. I'm going to cover the key audit areas, and I'm going to go into it and give a bit of insight. Obviously, I want to help people who are non-members and how you could structure an audit, and what you could put into it, and the sort of common things where we think people could slip up. But I can't outline the entire, it's a 12-page audit. and it's something you want to spend a bit of time on. But I can't obviously go into every single question on the audit, but hopefully I'll give people enough that they can take some value away from this and they can do something. I'm going to talk about fallow time and the current state, and what we feel at Code you want to be considering when you're auditing, but also what you want to consider for fallow time. And it's a bit of an interesting conversation because what's in guidance might not be what people are doing. And just to give, we're not saying you should do any one thing, just to give you my thoughts on it from experience. And then I'm going to talk about next steps. So I'm just going to move on from that. So responsibility. Some people might be saying, well, why do I have to do this? Why do I need to do, Alex, why are you saying Code? Why are you saying we need to do a COVID-19 audit? Well, in the faculty guidelines, in the FGDP guidelines, which are underpinning even the CDO stuff, it says all staff need to understand the importance of following these guidelines, and managers will be required to carry out regular audits to ensure compliance. So I think 3 months after, June, beginning of June was when we opened. We've done all our SOP work. We've trained everyone. 3 months to settle in, and then we probably want to do an audit because before mistakes get embedded or to catch stuff, I think this is the time that we need to do it. And I'll cover this later on, but I think we probably, similar to HTML 105, I think we probably want to do this 6 monthly. We're putting it in iComply as a 6 monthly audit for now. Obviously, when things get relaxed, we can change that and review. And obviously, if you feel it should be annual, then please feed that back. I think it needs to be done 3 months after we've started our SOPs, and then I think 6 monthly after that is quite reasonable for something as big as this. But also then, so some people might say, well, FGDP, that's private guidance. What about NHS? And I'm like, well, the NHS SOP basically says, from the 8th of June, you can reopen, but then moving back to full service is kind of up to your discretion as a practitioner, using your judgment and available information. And one of the key pieces of information you should be using, in my opinion, to reopen your practice or when you're going to be doing certain things is the FGDP guidance, because that links it to alert level. So right now we are at alert level 3, which means we still shouldn't be doing high-risk AGEs/AGPs, whichever terminology you use, on patients unless it's really, really needed. So the FGDP guidance really works in tandem with the CDO guidance in my mindset, and that's what we at Code we've suggested that you do for your SOP. So I do believe the CQC will be looking for this for NHS practices. I do believe they'll be looking for it for private practices, and it's part of the well-led key line of inquiry. The well-led key line of inquiry is all about auditing our processes and procedures and staying on top of things. So if we're auditing clinical records, if we're auditing HM 105, we really should be auditing our SOPs. So I think this is an audit for all practices, regardless of NHS or private status. So how to approach the audit. Number one, know your guidance. I've got that on the recommended reading, but if you should, everyone has built some SOPs based on guidance. I can't imagine there are practices operating right now without SOPs, or managers have really, really stepped up and done a phenomenal job, and practice owners during the crisis, and it's been, leaders have been made in this crisis, and people have had to step up and really understand guidance thoroughly in order to implement your SOPs, to do your risk assessment. So you need to know your guidance, and then obviously know your procedures. They're yours, and they should be based on guidance. So fingers crossed you've got those two things ticked off already. Never assume and never give the benefit of the doubt. If you're, it's very easy to sit at a desk doing an audit and going, oh yeah, we definitely do that, tick the box. Don't do that. Pick up your audit, go and look, because I can almost guarantee you that one thing you don't move from your desk to do is the one thing that someone won't be doing or won't be doing properly. And also never give the benefit of the doubt. You're auditing the practices. If you're auditing your own practice, why would you give the benefit of the doubt? If you can swing the needle towards yes or no, swing it towards no, because then you've got something to fix, you've got something to improve. If it's in the middle, don't give the benefit of the doubt. Let an inspector do that if they want to do that. But if you get an inspector in your practice or reviewing your evidence remotely, depending on what happens in the future, they could choose not to give you the benefit of the doubt. They could choose, well, the evidence says this, therefore this is what we're going with. So I think when we're auditing ourselves, we might as well be tough on ourselves. And also ask, could I prove it? At the end of the day, you know, if you're ticking yes on something, someone says, okay, prove it to me. Is your proof more than, well, I saw it? Or is there something in writing? You know, where there's something where you need evidence, make sure you've got the evidence and you've got it on file. These are just, you know, general audit things. And then obviously on your required reading, these are sort of the three main ones, I'd say. Obviously, if you're private, you're only going to really be looking at the FGDP guidance on the right. But why wouldn't you have a look at what the NHS is saying if they've translated it a bit, and then you're putting those into your SOPs? Obviously, CDO letters as well. And depending on what I've very much put English stuff on here, but obviously, if you're in Scotland, Northern Ireland, Wales, you know what documents you should be looking at, if it's the SDCEP documents, or if it's the well, it's not HIW, but if it's the Welsh documents. And yeah, so just make sure you know what your guidance is and just have that and understand that. And obviously, it's a really important point. If you don't know your guidance, you're not competent enough to audit. And you know, auditing, risk assessing is all about competence at the end of the day, of the person performing it. So 5 steps for effective auditing. I won't labor this too much, but it's just good to think of a lot of people, well, not so much these days, but sort of pre-2015 and when we did that transition to the key lines of inquiry in England, a lot of people were getting confused between logging and auditing. You know, you have data creation, so that's logging, that's writing your clinical records, that's performing risk assessments, creating evidence, but that's not the audit in itself. So you've got your data creation, and then you've got your collection, sort of putting those things together to check them, and then your analysis is looking at it and looking for trends. Obviously, this isn't a simple mathematic one like an X-ray quality audit, but you know, you want to be looking for trends. You want to be looking for, do you have everything on file? If you've been doing, in our system, one of the things is, you know, we've created cleaning logs. There's extra cleaning we want to be doing, environmental cleaning. Have those cleaning logs been being used? Get those cleaning logs together, the historic ones. And then obviously data analysis, and then creation and management of follow-up actions. That's the key thing. You know, what did we find? What was wrong? What did we do about it? What was the deadline for fixing that? And obviously with COVID stuff, with SOP thing, you know, if there's something wrong, your deadlines want to be really, really tight. If you're not meeting guidance, because obviously then the risk there is there's a potentially great risk there. And then obviously sharing and learning with the team. So discussion, training, team minutes, and having those on file, always your follow-up. And making sure that you share learning is the sort of share learning and continuous improvement are always the watchwords on this. Okay, so moving to the next one. So key audit areas. Now this obviously is a tricky one. How do you create an audit? How do you put it together? So we've broken it down into sort of 6 key areas. First one being practice management. That's covering things like your standard operating procedures, your risk management, what you've done laying the practice out. I've got slides on all of these points coming on, so I won't delve into it too deeply. You know, your PPE, your fit testing, clothing, what you're doing with it. I haven't got the washing machine compliance on this version of the audit, because obviously that was new yesterday, but that's something you might want to add to the audit now that you've got that information. So if you're making notes, that's probably something you'd like to make a note on. Appointment management, you know, patient categorization. What patients are you seeing? If you are seeing shielded patients, are you following the guidance? Have you created particular sessions in the day for them? Are you just not seeing shielded patients? Are you a UDC? So therefore you're fine to see shielded patients, but do your procedures say this? Are your procedures aligned to what you're doing? And there's a lot more in there, but I'll cover that as we go along. Obviously, environmental cleaning I mentioned before, and infection control. We've got all the fallow time. We've got the using chlorine, etc., or equivalent products that will destroy enveloped viruses. HR. Obviously, your human resources, your return to work risk assessments, making sure that your team well-being, that your team are good, are in a good place within themselves. That's been a real focus, obviously, through lockdown and beyond. Something the NHS are very, very keen on is you having team well-being policy. Making sure training, I mean, your proof of your training records, and any training that you did off the back of this audit as well, you'd want to do that. And then spot checks. In our audit, we've given examples of some spot checks that practices could perform, but obviously that's up to you. I mean, my spot checks would be based around maybe concerns that I would have. So one of the spot checks we haven't put in, but you could if you wanted to, was sort of set up in the surgery for an AGP/high-risk AGE. So you go into the surgery, are all the instruments out? Is it prepared properly? So you minimize drawers being opened and closed. You can build it around things that you want to check. To make sure certain things have been embedded within the team. And obviously with the team, this is not an exercise to find people doing things wrong. As I said at the beginning, you know, it would be very difficult to make this many changes this quickly in a practice and everyone to be doing everything perfectly. I think it's inevitable that we're going to find that some things need embedding a little bit more. Some people need course correcting on something. So obviously how you present this to the team, I think is important as well, because I'm sure they've all been doing a phenomenal job for you in getting the practice back open and running. Well, the majority of them anyway. We've all got, every practice has got one or two. So moving on from that, so now getting into the bones of the audit. And now as I said before, we can't spend an entire webinar going through every single question on the audit. So I'm just going to cover some of the major subsections under each of the sections as we've defined them and laid them out, and just pick up on some things that we feel are important. So in practice management, obviously starting with your standard operating procedures. So are your, do you have a set of SOPs? Are they up to date? Are they in line with guidance? That's obviously really, really crucial. And hopefully you've been keeping on top of the code news, where we've really been trying to tell people when we feel you need to make a change to your SOPs. There hasn't really been much in the last month. It's kind of settled, which is a really nice time. This is why this is a good time to audit. So your SOPs, and if you have changed them majorly, you probably want to keep old ones on file. And not have binned them, maybe for indemnity purposes. That's unusual. We wouldn't normally recommend that for policies, but it's a bit of an interesting case here. Competent risk assessment. So everyone's done a general risk assessment in their practice, and you've used a template. Was the person who did, as always with risk assessment, for anyone who's seen our risk assessment webinar, risk assessment essentials webinar, also, if you've not seen that webinar and you're wondering how to do risk assessment, I can highly recommend it. That's me chatting with Stuart Mann, who is incredibly qualified risk professional, and we're talking about where the common mistakes people make. And one of the two most common mistakes are people risk scoring incorrectly, and I won't go into that detail here, but making sure risk scores are correct. But also, if you're using a template, quite often what we will do, and other compliance companies will do, is they'll put in square brackets a lot of control measures that you could have for managing a particular thing. Now, what some people who are less competent with risk assessment forms will do is just keep every control measure on there. And then you'll look at that and you'll go, well, hold on, you're not using a pre-procedural mouthwash. I mean, that got taken out. We were talking about pre-procedural mouthwash before the FGDP guidance came out. And obviously some guidance, the Welsh guidance, still had it in. So I believe off the top of my head that was still in our template, but in England, quite a lot of practices aren't doing that. So have you left that in your template? Does your risk assessment say you have a control measure which you're not using? So that's probably really important to review at this time. Obviously, COSH, you've probably bought new cleaning products. Have you done COSH assessments on them? Are they on file? For your practice layout, have you evaluated the layout? Do you have the stickers on the floor with the distancing? Have you got your Perspex screens up? Have you removed the things that you needed to remove? Are your surgery surfaces all completely clear as much as they can? Are you taking control over who's entering, who's exiting the building? A lot of these are sort of mini spot checks within themselves as well. And what other things could we say under practice management? Ventilation. So really, high-risk AGE/AGP should not be being performed according to guidance, should not be being performed in surgeries that don't have any sort of mechanical ventilation or windows. So looking at that, if you've been contacted by track and trace, or you've had a COVID incident in your practice, have you properly logged it as an event in the code system using the G110A form? Have you followed up on it? Etc. Your stock management, have you made sure you've got enough stock, and are you staying on top of that? And sort of emergency procedures, have your have your team been updated on the Resuscitation Council guidelines? Can you prove that your team have been updated, or you have updated procedures around resuscitation guidelines which did change for COVID? And contingency arrangements, have you updated your contingency arrangements to include things like buddy plans, etc.? So quite a lot of, I probably gave a little bit more granularity there than I intended, but I think that's really, really useful to help people. So just moving on from this slide. So then on PPE, do you have your donning and doffing procedures in place? Oh, sorry, just bear with me 1 second. Okay, sorry about that. So for your PPE, do you have your proper donning and doffing procedures in place? Are they being followed? Do you have your designated areas? Fit testing, do you have your fit test certificates all on file? If you've had fit testing done yet, I know some people are still struggling with sorting it out, but have you got your fit test certificates on file for everybody, including failed certificate information? If you are disinfecting PPE, do you have proper procedures in place for that? Are they being followed? And on the clothing procedures, do you have a procedure in place for what the team are supposed to be doing with their clinical clothing, and is it being followed? So that one, the PPE one's quite easy. Just excuse me whilst I take a sip of water. I mean, obviously, I'm just giving the top level. We've got a couple of pages of questions on this within the audit as well, where we've really dug out where we feel, based on our experience of helping practices for 40 years and also what we see on inspections regularly. We've got a good feel as a team for where people might fall down. And obviously having 2,000 practices subscribed to our services, our inquiries team are on the phone every day to people answering questions, and we get a feel for what the trends are as well. So we built all of this into the audit. So appointment management, I mentioned it earlier. Have you developed a really clear how you are categorizing your patients? So sort of category 1 are patients with COVID symptoms, category 2, etc., and have you got an acceptance criteria? Is it being followed of who you're seeing? Is it up to date? Is it in line with the latest case definitions, etc.? Triage and screening, including NHS. The NHS has an additional requirement in that every call you should be doing clinical triage. For private practices, you don't necessarily, it's not as strong that you have that step, but it is highly recommended for practices. But is this written into your procedures? Is it being followed by the team as well? Do you have a patient attendance procedure? Have you put it on your website? Are you sharing it with the patient before they attend, so they know exactly how their journey through the practice is going to work and what they need to do and what they don't do? So is the communication right there? Chaperone arrangements, do you have a sort of an updated chaperoning policy or a procedure? Is that being communicated? Is it being enforced? Delivery procedures, the FGDP standard stipulates that you need to have a delivery procedure in place. We release that for our members. Do you have that in place? Is it being followed? Etc. If you're doing high risk AGEs at the moment, then as I said earlier, we are at alert level 3. So therefore, inspectors who are looking at this, I believe, would expect to see, if you've done a high risk AGE, that right now, is it justified in the notes? So not only are you doing your normal options, risks, benefits, consent sort of clinical notation, you also need to have written justification of why at alert level 3, when guidance says you should only do this when the clinical risk is higher than the risk to the patient, do you have those notes in place? That clinicians could come quite unstuck if they've not got that, if someone investigates it. So I think that's really, really important. And then obviously there's a lot of NHS requirements. We were talking about this, not strictly something that necessarily should come that comes straight out. It doesn't come out of the FGDP guidance, but there's a lot of things that the NHS were asking you to do in order to receive the funding that you've been receiving. And we think it's really important that NHS practices make sure they've got proof of these things, or are doing these things. So like the WTE assessments, making sure that you've done redeployment assessments. And I believe, I just want to minimize this screen a second. I do believe that in the handout section, we might have the redeployment assessment. Oh no, we don't have that one. Oh, that one's on the COVID. That's on our website. If people haven't done a redeploy, it's probably a bit late to do one now. But that is there. We do have some handouts in there today, by the way, which I'll touch upon. But we do have in the handouts section on here. We do have an excerpt, the first couple of pages of this audit. So if you're not a member, you can have a look at it and get a feel for what it looks like if you want to build one yourself. Obviously, we wouldn't give away the full audit. That's for iComply members only. And if you want some more information on that, by the way, I'll just get a pop-up on the screen in a second. So if you are interested in having more information about the audit or about iComply, then obviously now is a fantastic time to join, because we've just got that out there. It's been released in the system today and it's ready for practices to start doing. So we've also got the full practice risk assessment. So just in case you feel like you're risk assessed, when you start doing a risk assessment review, if you're not a code member and you're feeling maybe the template I used wasn't quite good enough, wasn't up to code standards, then our full risk assessment C204 is in the handouts, and that's available for everyone to use. So just going back to the slides. So environmental cleaning and infection control. Do you have your hand and respiratory hygiene supplies and posters up? Are they where they need to be in the practice, meeting guidance? Have you got cleaning schedules, additional cleaning schedules, checklists? Are they being followed? Are they being completed? Do you have a protocol for disinfection after high-risk AGs/AGPs, and again for the low-risk /non-AGPs? And are they being followed? Is adequate time being given for it? Obviously there's always pressures around, commercial pressures, etc. If you speak to your nurses, do they feel like they're being given enough time to do their job? Because the CQC will ask them those questions. And I also know the CQC were mooting the point of, I think it was on a webinar, of, how can they get more information, how can I put it? How can they get better information from team members moving forward? Are they going to do Zoom calls when the team member is not in the practice, so they feel like they'll get a more honest take on what the practice is like? So it's something we're always saying is, if your team aren't happy about something, that's a potential whistleblower. It's a potential someone who's going to say something to the CQC. So you really want to check that your team are happy with all of this stuff. They feel it's fair, they feel it's balanced, because an unhappy team member is quite often the reason you'll get a really unhappy team member that's not been dealt with, and a reasonably unhappy team member is a reason why you can get a whistleblowing incident and get an inspection. So moving on to fallow time, which is obviously a really sticky point at the moment, and what we can do, what we can't do. So I'm going to go into the audit questions that we feel you should be asking yourself, and then I'm going to sort of cover what the current state of fallow time is, and what our thinking is on it, and what you can do, what you could potentially do, and the sort of the risks around it, and how we feel you should be thinking about it. And then obviously it's up to you. At the end of the day, it's your practice. We're just sort of saying what's in guidance and and how an inspector could look at it. So the first question, actually, do you know what? I think I'll go through the questions first. The first question is, if the practice has reduced fallow time, essentially due to increasing measurable air changes per hour, specific to a room, does the practice have proof that this has been certified by an authorized ventilation engineer? And the next one is, if the practice has adjusted fallow time based on risk assessment to less than is allowable in current guidance, and or not by increasing measurable air changes per hour, is there evidence published in a peer-reviewed medical or dental journal to back up this time reduction? Now, I'll come back to these questions, but just going into the guidance and the information, in that there's what I'm seeing on the forums and what I'm seeing out there is there are some forms out there that are saying, if you use a rubber dam, tick this, reduce fallow time by 5 minutes. If you're using high-speed aspiration or a scavenger, tick this. If you're using a fogger, and you sort of tick all these boxes, and then you end up with a 10-minute fallow time that basically has currently no basis in guidance. So I don't think the regulators are going to be happy with practices using those forms. Also, according to current guidance, and I'm stressing this is current guidance, you're not allowed to reduce fallow time through use of a rubber dam, through use of UV, through use of a purifier, through use of HCOL fogging, of an air scavenger. All of these things currently are not allowable in guidance. I think this is going to change very, very shortly. And if you are using those things and you had reduced fallow time, then, you know, if you can back that up, and you honestly think you can back that up, then that's fine. I think it's slightly risky because I know that, say, the faculty, the FGDP, who you could say as a legal test are a reasonable body of peers. They're a group of dentists who sit down, review the evidence, and write guidance based on what they see out there being neutral and scientific, or as neutral and scientific as they can be about it. They have decided currently that you can't use those things. And they've actually said this, if people want scavengers, purifiers, all of these things to be considered for guidance, their test is, and going back to that previous slide, their test is there evidence published in a peer-reviewed medical or dental journal to back it up? Now, we do have the Four Nations Rapid Review document that's come out that does actually have some tables on what you can reduce and why, but it's not yet guidance. That's written as an information document to inform guidance. So those changes are probably coming, but probably who knows what happens when the FGDP or Public Health England, etc., get hold of that. Are they going to agree with it? Are they going to feel like it's scientifically sound enough? So what can you do? I mean, you could do all of those things, and if you had enough evidence to back it up, then an inspector might be all right with that, or they may take your evidence away, give it to a panel, and they'll decide whether or not you're in breach or something. Who knows? It hasn't happened yet. But there is one method where you can actually, the guidance does allow you to reduce fallow time, and that's by increasing actual measurable room-specific ACH. Basically, if you've got an ACH in a room of 10 to 12, I'd probably be more conservative and go to 12, then you can reduce the fallow time to 20 minutes. And that's clear in the guidance. And in Scotland, the CDO has actually come out categorically and said to Scottish practices, you've got a 60-minute fallow time, but if you can prove that you've increased this, you've had it measured and it's signed off per room by an expert, you can reduce that fallow time to 20 minutes. So it's quite interesting. What we've been saying at Code for the last sort of couple of months is this is the only thing that's really allowable in guidance. The Scottish CDO has come out and actually said it categorically. We haven't done that in England. I'm not sure why. But to me, it's then a balance of what you want to do. So if you really want to reduce fallow time, I think that's the way to do it because it's in guidance. If you've got evidence, peer reviewed or otherwise, that you feel, if you're going to reduce fallow time to 10 minutes because you've put a UV, a purifier, if you've got evidence to back that up, that isn't just a tick sheet that says reduce by 5 minutes, it's just an arbitrary, there's no evidence for that 5 minutes, then that's all right. If that's your practice, you're prepared to take that risk. And at the end of the day, you've just got to think of what I would say is the family member and or courtroom test, which is, if you had AGPs back to back and you had someone in who had an AGP and then you had a 10-minute fallow time because you've done all your tick sheet or you've got your evidence, would you be happy for your mum to go in that practice go in that surgery after that 10 minutes? Would you be happy treating your mum? If you are, that's good. Then that's fine. On the other side, I like the courtroom test, which is if it turned out that patient had COVID and this patient then got COVID, patient number 2 then got COVID, and the spotlight was put on your practice, would you be happy standing up in a courtroom and defending your position and saying, this is why I did it, here is my evidence? Would you be happy explaining that to the health and safety executive? Or if the worst happened, the really unlikely scenario that the patient got COVID, somehow it got linked to your practice and that patient passed away, or not passed away, or had a serious disability or something afterwards, because it's, that can happen after COVID, would you be happy, defending that compensation claim? Would your indemnity be happy? I think that's probably another question as well, is what does your indemnity say about this? would they back you up, or would they actually walk away at that point? So I think those are just considerations. At Code, we're not saying, you can only do this or you can only do that. If it was me, I would probably at this point be putting massive extraction fans in my walls and getting up the ACH, because that's in the guidance. I can do it. I think doing the other stuff is riskier, but there is a path to do it if you feel you can back it up. So I feel like I've laboured fallow time enough, and I'm sure there'll be a lot of questions on it or people disagreeing with me when we get to Q&A. So I'll just move on from this one. Okay, so next is HR team wellbeing and training. So, personalised risk assessments. It's been categoric everywhere that you need to do a really detailed quite a detailed risk assessment for your team members to return to the business. You might have a team member who has, a clinical team member who would like to wear full FFP3 all the time, because for no matter what they're doing, because at home they've got a partner who is shielding. So there are things that fall outside of the standard PPE and adjustments you need to make. If you've got a team member who's shielding, they really should be working from home at the moment. Ideally, they should not be in the practice at all. So have you made those adjustments? Could you prove it? Is it all on file? Have you done your practice meetings to train people, to talk things through, to have regular reviews? Have you got meeting minutes on that? Team mental well-being. The NHS guidance is very strong on having well-being policies in place and following them and making sure team have got the right support at the moment. So have you got those policies in place? Are they being followed? Do you have protocols in place for self-isolation, how to deal with what your team members should do, not only self-isolation, what they should do if someone in their family contracts COVID or they get a track and trace call? So do you have that in place? And sort of last but not least on the HR team wellbeing and training is training. All of this came with a massive requirement to really train everyone in their roles. And have you got those training records? Are they on file? Because I can guarantee you an inspector will want to see those when they next review your compliance. Right, and obviously all of this is in our SOP set. So we have got all of these protocols and everything. So if you're not signed up to iComply, this might be a good time to do so. Spot checks. I've given some examples here, but it's really up to you. Like I said at the beginning, I would be basing my spot checks on concerns I might have in the practice. I might feel that, and I'm just making this up, but I might feel that a particular receptionist is not quite explaining the attendance procedure correctly, or maybe isn't attaching it to every email, or I might feel that I've got a particular dentist who still has one work surface that looks like a paper bomb has exploded on it and hasn't really gone along with the clear all your surfaces. So I would be building my spot checks around concerns that I had in line with the procedures that I put in place. But the examples that we've got there obviously are observe a receptionist undertaking a pre-appointment phone call. Did they go through the attendance procedure? Did they give the right information? Did they follow up correctly? And then observing following a high-risk AGE appointment, observing is the decontamination process followed? Is the fallow time actually properly being tracked? And is it in line with what your procedures say your fallow time is going to be? Donning and doffing procedure, you could do that as well. It's up to you to decide, what you feel is going to be suitable. Sorry, bear with me 1 second. I just realised that my laptop has come unplugged, so we wouldn't want me going offline in the middle of a webinar. Okay, so that's pretty much I know I've gone through that very quickly. There is a lot there, and there's quite a lot of information. As I said, it is a 12-page audit in iComply, and obviously it's a really important one. I don't think we've ever had to do an audit as important as this up until now, because obviously this is, lives are at stake with being really honest, lives are at stake with coronavirus, and it's something we want to make sure that we've embedded this stuff and it is being followed. And if anyone investigates us, we want to make sure that we're right. I read about I don't know if people saw HSE started looking at workplaces in Manchester. Now, they were mostly looking at bars, but they closed a couple of bars down straight away because their risk assessments weren't good and people weren't following them. Now, I can't imagine HSE knocking on a dental practice door, but we are subject to their regulations, so you never know. I think it's good, obviously, to make sure that we have done this. So what have we covered? Obviously, we've covered responsibilities. This is coming from the faculty guidelines. It's coming from the well-led key line of inquiry. It's equally applicable, in our opinion, to NHS and to private practices, and I'm positive inspectors will be looking for this the next time they review your compliance. We've put this into iComply because we feel it's that important, and it is quite categoric in the guidance that it's required. Given some required reading, just make sure which SOPs. The FGDP guidance is pretty much universal for all regions, so that's always a good starting point. It's the first thing I would read if I was doing this, if I didn't already know it. Effective auditing, we've discussed, just not to get confused between logging and auditing. Auditing is the whole process of looking at those logs, of looking at the data, looking for trends, creating follow-up actions, doing meetings, sharing learning, just, making sure that you're following that whole process. There's about 5 steps to doing an effective audit. Key audit areas, I'm not going to go through that well, and fallow time, I'm sure we're about to hit the Q&A and we'll have a bit of a discussion about fallow time. So that is pretty much me done on that. Next steps, obviously check your guidance and your SOPs. Create or download your audit. Obviously, in the sample section, we've got like the first couple of pages that anyone can download, so you can have a look at how we've structured it. And then start. Hopefully, that'll get you thinking. If there's some bizarre reason you don't want to join iComply, I can't imagine there'd be anyone out there who doesn't want to be a member of ours. You could create your own, or you can download it from iComply if you are a member. I recommend everyone carries this out in September. I think sort of beginning of June was when we all started reopening, or 3 months after you opened your front doors is probably a good time to think about it. Manage your follow-up actions. As I said earlier, this isn't going to be, I'll always remember when I went to a practice once, and I think it was, I don't know when it was, like 2015, and they'd been doing HTML 105 auditing for what, 5 years, and they still hadn't bought keyboard covers, even though that's an essential standard. I said to them, you probably should get that covered off by now. But with something like your COVID-19 auditing, and with this, any problems, you just want to fix them immediately, I'd say, pretty much. And then I'd repeat 6 monthly for time being, unless your audit results are terrible, in which case you might want to do them sooner. You might want to fix and then do it 3 monthly, and then hopefully in a year or so's time, we'll have a vaccination in place, and we'll just be relaxing these procedures. This is why in the code system we created these as CDocs, and the audit is a CDoc, because we're hoping at some point we can retire this whole document set and we won't have a new normal anymore. We'll just be back to normal. So fingers crossed.